Doctor, can you hear?
Thank you very much. Welcome everyone. My name is Nadeem. I have done FCPS in Pediatrics, FCPS Neonatology, MRCP Ireland, and MRCPCH UK, and then DCH UK. I'm currently working in Ireland, and today we will discuss about the history station, general approach to the history station, and we will specifically focusing on the respiratory system. And I would really appreciate if we could have a volunteer to participate and do practice today. So if there is anybody interested, just write their name in the comment section, and we would need one volunteer. So I will start with basic information about the history station. So in the history station, actually, there are 4 minutes when the candidates would be waiting outside the room, and there would be information sheet having all the details about the case that you are going to encounter inside. So those 4 minutes are really very important, and I will talk in detail that what are the important piece of information which are required to be gathered during those 4 minutes. And then once you will enter the room, there would be 22 minutes altogether, which are divided into 13 minutes and 9 minutes. So 13 minutes are for taking the history, and then these 30 minutes are further divided into 9 and 4 minutes. So after the 4 minutes, you will get a warning bell that the 4 minutes are left. So you would have total 13 minutes to take the history, but after 9 minutes, you would get a warning that only 4 minutes are left. So you have to actually start, if there is anything important information you think that is mandatory, so try to come towards that point. And if there is any focus thing that you think is going to be missed, just focus on those areas in those 4 minutes. And if there are a couple of minutes left towards the end, that is also good. At least you have to organize yourself for the upcoming Viva, the discussion thing. So you can make your list of differential diagnosis and just a brief idea that what are you going to summarize, because the summary is really important. That is the first thing that you are going to have an encounter with the examiner, and that actually gives the reflection of your level of maturity, that how you compose your history, how organized you are. So there is, I always encourage the students try to, save at least 30 second or 1 minute towards the end, and try to be organized for the for the discussion of the 9 minutes. So after 13 minutes, there would be another bell, and that would be the point that you will start discussing your case with your examiner. So you would have 9 minutes. These are divided into 6 and 3 minutes. This whole time is definitely yours. And after the 6 minutes, there would be a warning bell that 3 minutes are left. So this is the way the station is run. And there are 10 minutes for this history station, which are actually divided by 2 marks in each for the 5 domains. And these domains are information gathering and history taking. So, like, if you have covered all the important aspects while you are taking history, you would get 2 marks. And if examiner is thinks so that there are few points left, but you have covered most of the area, then probably one. And if examiner is not happy at all, then 0 marks. So same would be the categorization for all these 5 domains. And you would notice that examiner would ask you few questions during the discussion. Why do you think so? This is the first differential diagnosis. What is the importance of this investigation? What is the importance of this management? Or would try to probe more about some certain aspect of the management or some investigation. So that would be actually would be assessing that if you have proper clinical reasoning for what you are saying. And then the management planning is that towards the end of the discussion, there should be some plan moving forward, that how would you manage this child in going forward. So that there would be 2 marks for that as well. Communication skills, your rapport and communication style. So that is also very important. Like you are actually having a good rapport and communication with the role player. You are putting the role player at ease, giving respect, showing empathy wherever it is needed. So these are very important bits. And verbal listening and communication skills. So you are giving attention and respect to the role player, to the historian, to the patient, listening to them very carefully and not ignoring their any points. You are not rushing, you are taking time, and you are trying to be a composed person. So these all things have marks. So they have very holistic approach, and they don't assess knowledge too much in MRCPCH exam. So they would be actually they this is a sort of exam. After that you are going to have your ongoing training in UK for next 4 or 5 years, and those 4 or 5 years would be there to build your further skills or your knowledge. But they are very concerned about your communication things, about your basic ethical approach. So basically, the correct word is the holistic approach they are assessing for. Okay. So be confident and trust yourself. So that's the most important thing, that you have to be the master when you are taking the history, when you are appearing in the exam. Sometimes people get confused. So never be confused. Be confident and smartly organize yourself in the 4 minutes. These 4 minutes are really important when you are waiting outside. So name and age of the child. This is the very is important thing, that you have to make a note on the top, you can say left corner of your of the sheet that has been provided to you. Just write very clearly what is the name of the patient, how old is the patient, what is the name of the mother. So it's a stressful situation, so you would definitely forget the name. But if you have made a very clear note of it, so on your sheet you would be able to have a quick look and gather the important information which you need really. And then the next important thing is, what is your task? So it's not only for history, it's also important for communication. So you should know actually what is the main thing that the examiner would expect you to concentrate. So make a very clear note of that thing. Sometimes you're rushing, the scenario is long, it's nearly a half page there, or even a bit lesser, but there are a lot of information, and the students are writing and writing the whole thing which is there. But by the time they reach to the task thing, the time is finished. So they didn't have a time to have a look on the task part, and then this won't be very impressive approach towards the station. So just make a very clear note of the child name and age, and then mom's name, and then the task. And after that, the rest of time is yours. You can actually spend that time in making a very clear read, giving a clear read of the whole scenario. So make a plan and arrange possible differential diagnosis before going inside. So it's recommended read the scenario very carefully, a couple of times if you can, um, and also write the important points of the history in the bullet points. So when you go inside and start taking the history, so you have to make a note of the important points. There is no need to write the whole sentences, but just make the bullet points. One are the points one, two, three, four, five. Because when you're summarizing, it's difficult to go through lot of information that you have written on the page. But if you have written very clearly like one, two, three, four, five, six, these are the four, five, six areas are the important points that you will address in the whole history, including the family, social, and everything. So that would actually give you a very quick way to organize your summary and present it in a nice manner. So make the note of important bullet points only, and keep the parents at ease and respect. If they have any question, listen to them very carefully. Don't ignore, and be opportunistic to empathize, to show your empathy if you think that there is something very stressful on their side. So be empathetic and respect their emotions. That is very important as well. Okay. Okay, we have Vivian in the chat box who kindly agreed to be volunteer for the task today. So Vivian, there would be you will have 4 minutes to make a note of this information, and then we will start the history station. As I discussed about the time, I would turn on the timer and we will be doing the station in the same manner as it would be in the real exam. And at the end, there would be some slides reflecting on your performance and also the important insight of the topic. Okay, you can start your time
Okay,
now. I will turn the timer.
okay, doctor. Thank you.
Thank you. I would request all the candidates to mute themselves. That would help us for smooth running of the session, please. Okay, we can start digging the history.
Okay, doctor. Okay, doctor. Good afternoon. I'm Dr. Lee, one of the PITS doctor here. Am I speaking to Mrs. Green, uh, mother of David?
Yes, please.
Hi. I would like to ask you some questions regarding David, and then I will make some notes if you don't mind. Then after that, we will come back to discuss about the management. Is it okay with you?
Yeah, that's perfect, doctor.
Hi, Mrs. Green, can you tell me about the main concern that you have for David?
Yeah, doctor, I don't know where should I start. Like it has been a long journey and very stressful as well. Like
Mhm.
like the problem actually started when David was only 1 year old, and he had bit of flu-like symptoms, and after that started breathing fast. We visited AD, and he was there for observation for a few hours. They said he is having bronchiolitis, and they discharged him. And since then, like he's having ongoing these wheezing episodes, and which are becoming gradually a bit more frequent. So I'm much worried at the moment now. My GP actually referred for this OPD 6 months ago. We were waiting for the OPD. It was a very long waiting list. I don't know why, but I'm really worried now about my child.
I understand this is upsetting. I will try my best to help you after this, okay?
Yeah, thank you, doctor.
Mm-hmm. So you mentioned that all the symptoms happen since 1 years old. May I know after that 1 years old, how does it progress? How bad is it? Like, how many in months of intervals do you have the symptoms?
Well, doctor, it's so hard to remember,
Mm-hmm.
but I think so that these episodes have happened nearly 8 times so far,
Mm-hmm.
and for the last there are nearly 4 episodes that I can remember in the last 1 year, and 4 episodes before that. And among these 4 episodes in the last year, he needed admission to the hospital for 2 days at about 1 year ago as well.
I see. This must be very hard for you, yeah? So I understand that you mentioned to me that you have been to GP. Did they did any investigation for you, and what is the management that they have given David?
No, Dr. GP didn't do anything, but he
Great.
was saying initially that it looks like viral illness. The children of this age, they develop the
Mhm.
wheezing because of viral illness. So he was of that perspective, but I was concerned specifically um, when he had an admission, and after that
Okay.
few months were fine, but he had another episode. I visited the GP and I asked the GP, and GP was convinced at that point to refer here.
Right. May I know that when the fast breathing happen, can you do anything to like make the symptoms better, or what is the trigger that will make it worse?
So I think that you want to ask like what makes the things better, and
Yeah, yeah, and worse.
yeah, and what makes it worse, what triggers it.
Yes,
So, yeah, so triggering, I don't know. Sometimes I even don't know that what triggers. Like sometimes there is a bit of flu, he starts having that. But even sometimes there is no flu, but he starts having the symptoms. So all of a sudden, he wakes up, and sometimes he cries, or when he's doing a bit of more activity, he's running around, he started having a bit of wheeze, and sometimes it gets resolved by itself, but sometimes the GP has given me an inhaler. I give that, and that helps most of the time.
Okay, I see. You mentioned about inhaler. May I know what color is the inhaler that you are using?
It's the blue inhaler. They
Okay, I
call
see.
it Ventolin.
All right. Um, may I know is there any fever when it happens?
Not all the time.
Okay, I see. Do David experience any like cold-induced symptoms, for example, when he's in a cold place or when it's winter that the exacerbation happen very more frequent than usual?
There is no specific association with anything.
Oh, I see. May I also know, is he allergic to pollen?
I couldn't find anything relevant like in specific seasons. I
See,
don't think so.
okay. May I know, is David allergic to anything, any food, any drugs? Sorry, any medications?
What, doctor, he had peanut allergy when he was
Okay.
about 8 months old, and he had the peanut butter for the first time and started having some skin rash. And
Mhm.
doctors actually told me that it would be the peanut allergy, maybe.
I see. May I know, is there any members in the family members that have asthma?
Um, yeah, actually, I had asthma when I was a child, and it was a stormy childhood for the first 6 7 years, but later on I gradually improved. Now I am fully outgrown of it.
I see. Um, Thank you for telling me this. And also, is there any family history of eczema and also allergic rhinitis, sneezing in the morning?
um like no excessive sneezing in the morning, no.
I see. Do David have these symptoms like eczema and also sneezing in the morning?
So there is no excessive sneezing, but David had mild eczema when he was a
Mhm.
child. So he's fine now. Like I don't think so. There is any
All
eczema at
right.
them.
Okay. Is there any pets or any furry toys at home?
Yeah, we had a cat. We have a cat at the moment. Yeah.
Okay. How about carpets?
Yeah, we have carpet at home.
All right. Is there any smokers at home?
No,
Oh, vapor.
no.
Mm, okay. May I know what in which area is your house? Is it in the industrial area or in this in the near to the paddy field where there's open burning? Is there anything like
Mm.
this?
No, no, doctor. There is nothing industrial. It's a nice, quiet town, and there is no industries. Industries are quite far away.
I see. Thank you for telling me. May I know, is there any sick contact this time? Like the previous episodes?
Uh, no,
No?
there was no sick contact. No,
Okay. How about travel history?
no.
Okay, I see. Did he change any milk recently? I mean, at the 1 year old time?
Sorry.
Is there any change of milk?
No.
Okay, I
So
see.
you have 4 minutes left.
Okay. May I know how does this impact your life and your child's life in terms of maybe weight and activity? Does it play well and sleep
Mm,
well?
well, I think that he's being quite affected. He's not playing that
Mhm.
much well. That sometimes he starts wheezing, and I he recently started going to preschool, and he got absent for nearly a week. When he was admitted to the hospital, at that time he was in crash, so he was away from the crash for nearly a week, and yeah, I think it's affecting him.
All right. Does he still eating well and still passing pee well?
Yeah, yeah.
Okay. How about the weight? Is there any reduce?
No.
Okay. May I know is there you mentioned that he was admitted to the hospital a few times, right? Is there any PICU admission, like the intensive care admissions?
No, they were thinking that at some point, like there may be need for ICU admission, but actually there was not
All
at
right.
all.
So does anyone tell you about the diagnosis?
No, that's my main question. I don't know,
Um,
like, what is happening there.
okay. May I know that for the blue inhaler, who will give the medic who will give the blue inhaler to David at home usually?
It's me.
Okay. May I know how are you using the medication?
Yeah, so actually doctors they gave me GP gave me a spacer thing. There's a small plastic bottle and there is a little mask towards the end. So
Mhm.
I connect it with that, and before that I actually give it a a good shake, and uh, then actually I press it one time, then he breathes in and out for nearly 8 to 10 seconds. Yeah,
Okay.
this is what this is what was told to me to do.
Mm-hmm. Did you ever wash the inside of the spacer?
No, no.
Okay. May I know is there any change of behavior or any change of behavior?
Uh, well, when he is unwell, he becomes a bit
Mm-hmm.
irritable, but otherwise, no.
Okay. Any night sweat?
Sorry?
Night sweats. Sweating
No
at night.
nightmares. No, no,
Okay. Is David ever tell you that his heart is racing?
no,
Okay. Any problem with the pee and poo?
no,
All right. Any problem with the eyes, hearing?
no,
Any skin marks? Any rash?
no, not at the moment.
Okay. How about the joints? Is there any muscle pain?
No.
Okay. Can I check with you about your David's birth history? Is he born on time?
Yeah,
Okay. So how about the immunization? Did he get the jab everything complete?
yeah, yeah. He's fully
Okay.
up to date.
Okay. Is there anything that I need to know about the diet?
No, no, his diet is great.
All right. How about the development? Do you have any issue?
No,
Okay. May I know who is working in your family? Is there any financial issue?
thank you very much. So your time is finished,
Oh, okay.
and you can start summarizing your findings.
Okay. Um, Today I've spoken to Mrs. Green, mother of David, um, who has a main concern of flu symptoms and fast breathing for the past 3 years. It started at 1 years old, and for the last 1 year, he had already 4 episodes that need ward admission, but there is no PICU admission so far. Um, the the mother has bronchial asthma up to 7 years old, and the child had peanut allergy and also eczema and exercise-induced symptoms. However, he has no cold symptoms, no pollen-induced symptoms. He is using an inhaler, which is Ventolin, which the mother informed that he gets better on Ventolin. The medication was given by the mother. I checked the spacer usage that he's quite good with the technique. And mother is greatly concerned because it's affecting him sleep and also play-wise. He had been absent from the preschool for around 1 week now. And the mother is mainly concerned regarding that. And then she wants a diagnosis. Thank you, doctor.
Mm. Okay.
Mm. Yes, sir.
Perfect. And what is your differential diagnosis?
My top differential diagnosis would be recurrent viral-induced wheeze. And also, I would like to put primary immunodeficiency in my list, and also TB. Um, yeah, this three is my main differentials. Recurrent pneumonia also.
Okay. So why is viral induced with your first differential?
My viral illnesses is my first differential because of the age. Is less than 5 years old, and he has multiple history of parents say bronchiolitis, flu symptoms, and also fast breathing, which gets better with Ventolin. Sorry, and the mother also have like childhood asthma, so there is positive family history there.
Okay.
But I couldn't diagnose asthma yet because it's 4 years old.
Mm-hmm. Okay. Are you concerned for this child to have asthma
Uh,
in future?
yes, yes, he has a strong asthma predicative index. So I would advise the mother to come for like regular follow up so that we can follow up on asthma in the
Okay.
future. Yeah.
Okay. How you will investigate the child?
So for this child, I would first do a routine blood test to test that whether he's like on whether he is on any infection right now. So FBC, CRP, and also ESR. And if there is septic symptoms, then I will take a blood PNS culture. And also I will check the sputum. I will stand for sputum investigation. Since I have the differential diagnosis of TB high in my list also, I will check the AFP and also mental test and also do a chest x-ray. Then after that, when he's 5 years old, I will do a spirometry test and pheno. Yeah.
Okay. Perfect. Anything else you want to mention in
Mm,
investigations?
mm, I don't
That's
know.
fine. So how you will manage this child?
So for this child, uh, this is OPD. I will put the child on a regular follow-up. I will give a cough diary for the mother to chart whenever he has symptoms. And then I will advise the mother on the usage of Ventolin that she have now. And since there is very, very frequent admission and or very frequent exacerbation, I will do a trial of budesonide, MDI budesonide. I will recounsel the mother regarding the spacer usage, MDI usage, and how to wash the spacer properly. Also, then if there is, um, I can try Montelukast also in the future. And if it's not going well, then maybe try long acting this one LABA long acting beta blocker, and also as a beta blocker beta agonist. Um, and what else?
Okay.
Mm,
Anything else?
mm,
You have time if you want to add anything else.
I would like to ask the mother for any good history also, if there's any upsetting.
Okay. Okay.
Pig
You have
meter.
3 minutes. Sorry?
I will do a pixometer also. Just now I forgot about that. And then
Okay.
if if I reach the space for Montelukast, and the symptoms is not well controlled yet, then I would consider referring respiratory multidisciplinary team. Thank
Perfect. Thank you very much.
you, doctor.
So, how do you feel yourself?
Uh, for my history taking part, I think I don't have enough time to finish the social part.
Mm-hmm.
I should have. I don't know if I should have asked less about the symptoms, but there's just a lot of things that I need to ask.
Yeah, it was a difficult situation and difficult scenario actually. So you're
Mm,
right. Anything else you want to reflect on yourself?
mm,
Okay, so that's fine. So it was really a great effort, and I really um, say thanks to the students who come forward and they actually take it as an opportunity to enhance their skills and also give a chance for others to actually remain engaged during the sessions and learn. So this is the way we learn from each other. This coming forward and participating in the session doesn't mean that there is something personal judgment or anything. We all are here to support each other, to help each other. And what actually matters that finally you should be able to pass your exam. And that's the main goal, and that's the main thing. Your communication style and your listening things were very good. So I would say your history technique is an excellent. Definitely, there is some room for improvement, and a bit of the actually NHS and RCPCH exams. They always expect the focused history. So as you mentioned yourself that ask a bit more focused questions, and if you don't go into details of few little things which are really not that much necessary, you would be able to actually have a time to ask some very particular question. We will discuss all those questions in the coming slides. And but overall, I would say that you covered lots of details which were really important. Few important thing is, family history was very important here. You ask about any associated other allergies, you ask about the eczema, you ask about the possible triggers, and actually you ask about the total number of presentations and you summarize it very nicely towards the end. That was really nice. So a lot of positive things, yeah. And then there are few things that I would like to add. Like you were asking 2 to 3 questions in the same phrase. So like when you ask the triggers, you name 3, 4 triggers. It's difficult for the parents to answer that. So always ask one thing one time. Like similarly, you were asking about the eczema and rhinitis. You were
mhm.
asking about probably the treatment
Um,
responsiveness, and
yeah.
there was an yeah, so that was actually another thing you so that was really a very important point. Rather, I would say that was the most important point. So it was better to ask separately. So it was good to ask actually a bit of more details of the treatment that has been given. Like it was fine you ask the inhaler which the child is taking, whether any courses of inhaled oral steroids were given, was any asthma action plan was given to the parent, were they following the asthma action plan, and so how many courses of oral steroids. That actually sometimes helps us to find the severity of the situation. That child is getting a lot of oral steroids. So, and ask very clearly, like, does ventral inhaler make the improvement? Does he feel better after that? So very clearly, so that's the most important thing that is going to make difference towards your diagnosis perspective, your further management perspective, and that was very important. And then another important thing was to ask about the severity of the viral wheezing symptoms of the wheezing symptoms. So like if the wheezing have been happening more than twice a week, that needs salbutamol inhaler, they are happening two or more than two nights, waking the child from sleep in a month. They are affecting the lifestyle. He's unable to play around. He's unable to participate in activities of life. Not being able to miss. He has been missing the school a lot. So, that would be a bit more better. You ask about the school, I know, but these other two questions were also important. And the need of the salbutamol inhaler, how frequently the child is using it. Is he using more than twice a week? That actually points to start the treatment of the maintenance inhalers. So that was another important thing in the history. And you asked about the technique, that was very good. And another thing was the compliance. Is the child is compliance towards the salbutamol or asthma action plan? So that was actually very important, though child was not on any regular treatment, so that's why compliance was not that much important. But if child is started on asthma action plan, so that might be a bit of helpful, but not that much if the child would have been on the maintenance treatment. So yeah, perfect. Now, coming towards your differential diagnosis. So you mentioned that this child is having viral induced wheeze. This is what you mentioned, yeah? Your first differential viral induced wheeze.
Yes, the recurrent viral induced wheeze.
Yeah. So there were some interval symptoms actually here in this case. So though there were some viral triggered wheeze, but even untriggered wheezes were there. So
Yeah,
you
yeah,
can say like
multiple.
this. Yeah, you made a note of it later on towards the discussion when I ask his child is prone to have asthma. So you can simply say this child is having recurrent wheezing. The wheezes are actually viral infection induced, and even there are interval symptoms when there are no viral infection, but child is still having wheeze. Even when the child is playing around, child is doing some activity, being emotional when he's crying. So this and there are few things which are strongly suggestive that child may have um, asthma in future. I would like to exactly calculate the asthma predictive index for this child. And so that would have been another way to just, sometimes the differential diagnoses are not very clear. Then you have to play in a smart manner and just to cover a few things in the one phrase. So that would have been the nice approach. And so the investigation, apart from that, the other the differential diagnosis, um, rest of the differential diagnosis, like maybe recurrent pneumonias, maybe some airway malformation. So there can be anything, as you mentioned. I won't disagree with the rest of the differentials. Investigations, you said about the baseline blood investigation. So FBC is really important. Eosinophilia is an important component. And this child was having a bit of peanut allergy, though there was no other obvious triggers. So might be beneficial from by testing the allergy testing. And the other thing was at this stage, the most important thing was to check the salbutamol responsiveness. Spirometry and the other investigations are we won't be able to do at 4 year of age. You
Mhm.
mentioned AFB, is it?
Yeah, yes.
Yeah.
The
So
T for the TB.
sorry.
Because one of my differential diagnosis is TB.
Mm, yeah. So TB is one of the differential, but I would say don't mention it because this child is really not fitting in the criteria of the tuberculosis. So when you are
Mhm.
giving the investigations, so actually you are giving the investigations for your top differential. When you are giving the differential diagnosis, you can mention few things which are down the list and maybe a bit more irrelevant. But investigations, you have to justify your investigations. So, and better to avoid it. And also, you mentioned chest X-ray. Chest X-ray, some physician do a baseline chest X-ray, but actually, it's really not indicated even in mild exacerbations or mild to moderate exacerbation of the asthma, unless you are thinking that there are very obvious crepitations or the child is really sick that needs some sort of ICU admission or magnesium sulfate. So if child becomes unwell to that extent, it's worth doing chest X-ray. And chest X-ray doesn't have any established significance in making the diagnosis, but some physicians use it as the baseline thing. Yeah, and if child would have been unwell at the moment, so it's definitely there are few other things like respiratory virus screening that would have been important, and if there are anything suggestive of the sepsis, which were less likely to be. But you didn't ask about the current situation. When was the last visit? So yeah, these are the few bits that I would like to add, and then management definitely. This child is really having quite lot of things suggestive towards the maintenance therapy, so would be a candidate to start the inhaled corticosteroids and trial of the inhaled corticosteroids, and then follow up in 8 weeks time to see the progress. So again, I would say that you did an excellent job. You volunteered yourself, and uh, y- your history style is very good. Your differentials were very relevant. And same was with the investigation, the management. There are few things that we will discuss in the coming slides, and hope so it would be helpful for all of us.
Thank you, doctor.
So for the yeah, thank you, Vivian. Thank you. So ask questions to yeah, sorry. So in case of history, ODS para, onset duration, severity, progression, aggravating relieving factors and associations, and then systemic review. This is a generic, wheezing, is wheezing getting better or getting worse? What makes it better? What makes it worse? And are there any specific timing for how long it is? How did it started? And all these things are very important. And then in associations, there are a lot of other things, like all things, all the questions that I would discuss in the coming slides about the asthma predictive index and multi-trigger V's. So these would be a bit of more associated questions in associations. And systemic review is also important, just to have a quick review of the rest of the system if the child is having any other established health condition or ongoing conditions. So detail of the total number of presentations to the GP and to the hospital, exact details, like in this case, the details were very clear. Like there were 4 presentations up till age of 3 years, and then 4 presentations in the last 1 year, including one hospital admission. That was actually the candidate asked in detail, not in that much detail, but ask about was there need for ICU admission. So it would have been better to ask like for how long the child was admitted, what treatment was given, did he needed any respiratory support, was it non-invasive modality of the ventilation, or there was some condition got worse to actually there was there need for any mechanical ventilation. So these all details are very important in history of wheezing or asthma. And then investigations, again any investigation if they have been done, and management that were done during these presentations. So take detail of use of the salbutamol and its responsiveness, and oral steroid courses, the number of the courses. So that is actually very helpful to find the severity of the situation. Ask question to establish the asthma predictive index. Asthma predictive index is used in children between 2 to 5 years of age with episode of the wheezing during the first 3 years of life. Child is predicted to develop asthma if had four wheezing episode in the past year with at least one confirmed by the physician, plus one major or two minor criteria. So what are the major criteria? Parent history of asthma, and physician-associated atopic dermatitis, sensitivity to the allergies in the air as determined by physician through positive skin prick test or blood test allergens such as trees, grass, weeds, molds, or dust mite. Minor criteria blood eosinophils more than 4%, wheezing unrelated to cold. That is very important. And doctor diagnosed allergic rhinitis. And so if there is actually atopic march, allergy to milk, eggs, peanuts, or other allergic stuff. So this is very important to ask these relevant questions and then differentiate between the episodic viral induced Vs and multiple trigger Vs. So was there any viral infection? Are there any other triggers like cold weather, exercise, emotional disturbances, pets, smoking, or pollens? So these are important to ask and then address these as well when we come towards the management. So if we think that if there is any strong association, it's better to investigate that. And if anything comes in the allergy testing, it's better to avoid that thing. So interval symptoms, wheezing between the episode without viral illness, or the child was well between the viral illnesses. Family history of asthma, age more than 2 years. So these two things are really important. I would tell all the students actually always ask the questions related to it, asthma protective index, and for there should be 4 wheezing episode in the past year, plus one major. So the major is family history, first degree relatives, especially parents, physician diagnose asthma, physician diagnose atopic dermatitis. If there has been sensitivity, any aero allergens have been positive. So either by skin test or by the specific IgE blood test, and then minor criteria, the blood test having eosinophils and the wheezing, which is interval symptom actually, allergic rhinitis or any other allergies to non-aero allergens. So these are important really, and differentiation between the viral induced Vs and multiple trigger Vs. So if there has been viral infection, it means it's viral induced Vs. But if there are some interval symptoms, it means that there are some other things going on the background which are actually triggering these episodes of the wheezing even when there is no viral illness. So that is important to differentiate. And are there any other factors are the triggers which are actually triggering these wheezing episodes? So the virus is one thing, multiple other triggers is the second thing, and then the interval symptoms is the another thing, and then family history of asthma, and it should be more than 2 years. Under 2 years, the children are a bit more prone to have the viral wheezing, so we give some time. So, if known case of asthma, I'm just telling, not specifically to this case, if child has been diagnosed with asthma. So it's important to ask when child was diagnosed, where was diagnosed, how was diagnosed, what investigations were done, what treatment has been given so far, total number of, so exact details of the treatment, and if treatment was modified or changed, when was the treatment last changed, who changed it, what was the plan after that, how to move forward, total number of admissions, including the ICU admissions, services the child is currently linked with, any respiratory physician, pulmonologist, clinical nurse specialist of asthma. So these all are very important, and follow-up management plan. When was the child last seen in the outpatient department, and what is the plan to see the child next? So any planned follow-up in the upcoming months, and is family counseled and trained about the inhaler technique, and what is the compliance of the treatment, and any are there any environmental factors leading to recurrent wheezing, have parents been counseled about the asthma action plan, systemic review, birth, immunization, nutrition, development, family, social history. These are a bit of points in the history which I would like to highlight, and these are really important. So investigations. So So the children who are actually between 5 to 16 years of the age, they are diagnosed with asthma if they have signs and symptoms which are suggestive of asthma and have obstructive pattern of spirometry and positive bronchodilator response, which means 12% increase in FiO2 after giving the bronchodilators. So that is about the older children. And so obstructive pattern of spirometry. So we all know that there are two patterns. One is the obstructive pattern, other is the restrictive one. So in case of obstructive things, F force vital capacity has always been increased. So definitely FEV1 is reduced. So FEV1 is FEV1 by FVC. That is actually the ratio that we find out. So if FEV1 is reduced and force vital capacity has been increased, definitely the ratio is going way down, less than 70%, and that is typical obstructive pattern that is generally seen in case of asthma patients. And then fractional exhaled nitric oxide more than 35 parts per billion, and peak flow variability of over 20%. So it should be either obstructive spirometry with bronchodilator response that makes a diagnosis, or pheno with peak flow variability that also makes a diagnosis. But if there is only pheno more than 35 or peak flow alone is over 20%, then in that case, treatment should be given and see the response. If there is strong clinical suspicion but none of above criteria is meeting, so in that case, if you are concerned, make a referral to the respiratory physician. So it's difficult to diagnose the children under 5 year if they can't actually undergo these objective tests. In that case, we actually see the clinical responsiveness to the salbutamol, and then if there is need, we start them on inhaled corticosteroid and see the response. And by the time they become 5 year, then they would be definitely in the more formal, in a more formal way, they can go through the formal testing. But under 5 year, it's all about the clinical suspicion and the clinical responsiveness to the trial of treatment. Okay, so if child is more than 5 year, generally what they do when they think, so they try salbutamol for a short-acting beta 2 agonist for 8 weeks, and they see how often the child is needing the salbutamol. If it's not known before, like if they really think so that the child is needing salbutamol for more than 2 times in a week, child is having wheezing quite frequent, more than 2 times in a week, having wheezing more, is awaking the child from sleep more than 2 times in a month, or the child has not been able to perform the activities of the daily life and is affecting his lifestyle. So all these things mean that this child needs ongoing maintenance treatment. That is a low dose inhaled corticosteroid that we give for 4 to 8 weeks, along with the short acting beta 2 agonist as a reliever treatment. And then we see the response. If child is not improving, then we step up to add the leukotriene receptor antagonist for 4 to 8 weeks, along with the SABA being used as a reliever again. And if child comes back in 4 to 8 weeks and is not improving, then continue low dose inhaled corticosteroids, stop LTRA and add LABA for 4 to 8 weeks, and continue SABA as a reliever. And if child is not responding to that, then they give MART trial. That is a maintenance and reliever treatment. That is only one inhaler having a combination of the maintenance and reliever medications, which are generally low dose inhaled corticosteroid and LABA. LABA as you can say reliever as well as the maintenance, and inhaled corticosteroid as the maintenance as well. So they give a combination of this for 4 to 8 weeks, and if there is still no improvement, then they give medium dose inhaled corticosteroid with either mild or fixed doses of LABA and inhaled corticosteroid. So that means they would increase the dose of the inhaled corticosteroid. They can give it as a combination of the medium dose inhaled corticosteroid with LABA as a MART inhaler, or they can give separate fixed doses of LABA and inhaled corticosteroid, and keeping SABA as a reliever in that case. Like if you're giving MART, there is no need to give the reliever inhaler. But if you are giving the fixed doses, then you will have to give reliever in form of SABA. And if child is actually not improving, so definitely this is the time to take the help from the respiratory physician. And dose of the inhaled corticosteroid, if it's less than 200 microgram, that's a low dose. 200 to 400 microgram is the medium dose, and more than 400 microgram is the high dose of the inhaled corticosteroids. So just to summarize, so initially we start with the SABA and we see how the child is needing SABA. If child meets the criteria for the ongoing treatment, so we go for low dose inhaled corticosteroid, and we always give trial for 4 to 8 weeks, and we add SABA as a reliever. Child is not responding to low dose inhaled corticosteroid, that is the first line treatment. Then we add LTRA, leukotriene receptor antagonist like montelukast. If child is not responding in 4 to 8 weeks to that, then what we do, we continue low dose inhaled corticosteroid, stop LTRA, and add long acting beta 2 agonist, that is LABA. And so we give that trial. If child is not responding, then we go to the fixed regime, that is MART, including the low dose inhaled corticosteroid and LABA as a maintenance and reliever therapy. If child is not responding, then we increase the dose of medium dose, that can be given either separate medium dose inhaled corticosteroid along with a fixed dose of LABA, or in form of the MART, having medium dose of the inhaled corticosteroid with LABA, that would be given as both maintenance and reliever. And if child is not responding to that level, so then we take the help from the respiratory physicians. I hope it is clear. And if child is less than 5 years, like in our case, then we give short-acting beta-2 agonist for 8 weeks and see how the things are going. Like in this case, the child was taking SABA for quite long time, and there are quite frequent things happening. So sometimes in that case, we go straight to 8 weeks of medium dose inhaled corticosteroid. That is not actually the maintenance thing, but that is a trial, and we give trial with the moderate dose. Not with the low dose. And after the 8 weeks, what we do, we stop the steroid inhalers and we see the response. So if there is no response, if there is no response to the treatment or the resolution of the symptom, they don't resolve. So it means that it's not asthma. Consider some alternative diagnosis. You can refer to the respiratory physician. If symptom resolved but recurred within 4 weeks of stopping the steroids, maintenance with a low dose inhaled corticosteroid is recommended, and this confirms the diagnosis of the asthma. And like in this case, definitely you can't say the child is have asthma under 5 years, but you can simply say the child is likely to have the asthma in future. And symptom resolved but recurred more than 4 weeks after stopping the steroid, give another trial of 8 weeks of the moderate dose inhaled corticosteroid. If child is on the low dose inhaled corticosteroid uncontrolled, add LTRA. If still uncontrolled, get specialist consult, respiratory physician opinion, and they would help you moving forward. Make sure the parents have been taught about the correct inhaler technique, and they monitor the response at home with peak flow meter, keeping in view their age, and they maintain the record, the diary, and they should come for the regular follow-up and counsel and make sure about the inhaler techniques, space devices, and face mask if needed. So the children who are actually So they always recommend in children the spacer device. So the spacer device is a device that is actually attached to the inhaler, and then there is towards the end of the spacer device, there could be actually a face mask that is actually for very small children, usually under 4 year of age. You can just put on the mask on their face because they are not old enough actually to understand to take the mouthpiece in their mouth and just follow the command. So it's difficult for them. And you actually put the face mask and they are just breathing the normal pattern. Um, so that is the actually thing behind why to use the face mask. Now, so when the child would be coming for the follow-up, there could be poor control, partial control, or good control. So there is, in this slide, there is a bit of problem. I would say the poor control would be in the last column on the right side, and then partial control would be in the second column from the right side, and the good control would be on the third column from the right side. So just, in the first column, there are only symptoms, daytime symptoms, need of the reliever, inhaler, limitation to activity, and nighttime symptoms. So I will explain it in detail. This is very important slide. So daytime symptoms, if you think that the daytime symptoms are less than 2 days, 2 or less than 2 days per week, then it means it's a good control. And if there is need for more than 2 days per week, it means it's a partial control, or it could be poor control. And then the need of the reliever inhaler, as we discussed, according to the severity of the symptom, there is need for a reliever inhaler, so it would be the same as the daytime symptoms are. Then limitation to activity are none in case of good control. They are present to somehow in case of partial control, and they are very bad in case of the poor control. Nighttime symptoms, these are non-present and present. So according to the severity, these are generally present. So if child is actually waking at night more than 2 times in a month, so that is actually significant to come towards the partial or poor control. So we always review once child has been controlled in terms of the symptoms, and you think things have been getting better, we keep them on inhaler and we follow them in 6 to 12 weeks. If it's poorly controlled, check the correct technique and adherence means compliance prior to stepping up. Because if even you step up and the technique is not good or the compliance is not good, so it means nothing is going to work. So remember the words of ICE. ICE means I is for inhaler technique, C is for compliance, and E is for the environment, means triggers. If there is anything triggering around, even if you have your correct technique, your compliance is good, but there is someone smoking at home that is triggering this, so you have to remove the trigger, you have to sort out the trigger. So this is very important to understand. So whenever they come to the clinic, they come after the acute exacerbation, always use this ICE words just to make a clear insight of the things going on the background. Consider alternative diagnosis, even everything is good, there are no triggers, maybe something other going on, maybe some immunodeficiency, some bronchiectasis changes, maybe there is some underlying pathology is going on. Consider step up if indicated. So good control for another 3 months suggest preventer inhaler could be stepped down. So if there has been good control, there is no need for blue inhaler in 3 months, or there is need for less than 2 times in a week. This means like the child is doing pretty good, and that could be the best time to actually reduce the preventer treatment and continue the lowest treatment that controls the symptoms. So if we have to step down from the medium dose to the low dose, or from the low dose in combination with something to the low dose only, so try to out take off one thing at one time, see another couple of 4 to 8 weeks, and still things are better, you can step down. So only cease treatment after a period of 3 months, symptom free, and review 4 to 6 weeks after stepping down. Consider ongoing treatment of triggers and seasonal factors when stepping treatment up or down. Like there are many children who need high doses during the winter season from October to March, and so during those, if you think the child has come to clinic in October time and has been doing good in the last 5 6 months, but the last year winters were terrible for that child and child needed an ICU admission. So you're not gonna step down even the child has been good towards the treatment, because that's the worst season for him in general, where there are a lot of triggers which make him bad. So you would wait until another 6 months are passed and this terrible time is gone, and you would be more comfortable and more confident to win at that stage. So consider ongoing management. Yeah. So education, assess knowledge and understanding, address gaps on symptom recognition and management, when to seek medical attention, emergency management. So these are all, tick box that you have to do. You have to give them very clear plan about the asthma action plan. All the children should have a written personalized asthma action plan to use at home and at child care. So they actually have very clear plan to use salbutamol inhaler a bit more frequent for 6 to 7 days when they are unwell. So that really helps them to prevent the hospitalization. They can manage at home. If they have very good plan, there would be less need to come to hospital. So that would really help for the patient, for the parents, and even for the whole community. And check adherence at every visit and address barriers. Recommend annual influenza vaccine. Inhaler technique needs to be checked. Role of reliever and preventive treatment needs to be explained. What these both are going to do. So emergency management. So if generally, they say if child, you think the child is breathing very fast, there are deep sucking movements down in the chest, also in at just in the neck area. Our child is very sleepy, very tired. He's having bluish discoloration around the lips. He's unable to complete the sentence. This means your child is really unwell. You have to call the ambulance and then give. So less than 6 year 6 puff and more than 6 year 12 10 puff. You have to give every 20 minutes until ambulance is outside the door and is ready to collect the child and take over the treatment. So this is the thing we tell to all the patients. That's a part of asthma action plan actually. And yeah, if child is not responding, review if asthma is correct diagnosis, review adherence, review inhaler technique, respiratory referral. Inadequate asthma control achieved at step word means that it's beyond your scope. You need a respiratory physician, or the diagnosis is uncertain. So there are few things going on in the chat. I will have a quick look if there's any question. Similar body, foreign body, aspiration, gastroesophageal reflux, cystic fibrosis, past medical history, birth history, prematurity. What is the diagnosis? So we have discussed all these things during the discussion. Thank you for your input in the chat box. Has anyone any question?
Dr. Nadeem, may I ask something?
Yes, yes.
Doctor, just now when you asked me about the investigation, should I start straight at the investigation, or should I go for my, like physical examination? Then I will see is there any factors, is there any hyperextended chest, Harrison sulcus, then only go to investigation, or should I just start with like
Yeah, that's a very good point. And you can simply say, I will do a detailed examination of the child and would try to find out if there is anything suggestive of asthma on examination, and then come towards the investigation. It looks nice. I personally like it, and I personally did it when I was in the exam phases. So it looks nice. Like it's a history station. You can't do the full examination, you can't explain it, but it's good to say in one phrase, specifically in the scenarios where there is a bit of confusion going on, like what should be the investigation. There are only few limited investigations, like in this case. Yeah, that's a good idea.
Thank you, doctor.
Thank you. Dr. Sarish, I think, raised the hand.
Yes, Dr. Nadeem, I just had one doubt. Like this patient was not diagnosed. It was a newly it's not even new diagnosis. So whether the question of inhaler technique was appropriate in this case because it ate up a lot of time. So I was wondering if this is not a diagnosed case, should we ask this question, or if it's only important in a patient who is we are suspecting non-compliance or already diagnosed, for example. Thank
Yeah.
you.
Yeah, thank you for raising the point. So in this case, child was using the salbutamol inhaler. So we just wanted to review the inhaler technique. But you're right. Like when I was actually coming towards the discussion point, I was covering the asthma in general as well, and I was actually trying to highlight at some points the age and all those things if child is a known case. So in asthma thing, even if it's not established and child is on salbutamol inhalers, is using the inhaler anyway, it's good to ask, is your child using any spacer device? How they are taking care of the spacer device? Is there any face mask attached to the end? And so another important thing is you can simply say, has someone demonstrated you how to use the inhaler, and who demonstrated you? Are you happy with the technique? Can you just quickly go through with me that how you are using? So that is another way. But you are right, like in this case there was no ongoing treatment, no ongoing inhaler, maintenance inhaler, but child was on rescue inhaler though. But it's better to ask, even child is on the rescue inhaler. Okay, is it clear?
Yes, thank you. That's fine.
Okay, any other points, guys?
I think I'm not sure if I missed. I think more asking about CF differential would have could have been explored. I think it was also limited time, but repeated ear infections could have been asked more because when you gave a very detailed history at just the starting of the history, it was quite at least 30 seconds. So I got an impression it could be CF as well. So, but that was not explored during the history.
Yeah, there is no harm in asking, cystic fibrosis could be one of the differential as well. So that's a good point. It's good to ask in a systemic review or any family history of any other respiratory symptoms, any other chest infection, ongoing chest problems, any family history of ongoing chest problems. So that's a good point. It's good to add it in that differentials or associations part. Any further questions? Okay, thank you very much for your participation. I hope this would help some of the students, and thank you. See you next time.